one neurotransmitter involved.
Okay.
This is where I'm wanting to get into ionotropic.
Since we talked about this already, you should have a higher level of comfort factor. The cushion seat you're sitting on should feel a little bit more squishy than a sharp rock. So you're gonna, if we just started this today, it'd be a little, what are you talking about? It may still be that, but hopefully not as much. So remember, we have two locations where we have acetylcholine being released. And can I erase this picture? You guys take what you need, drink break? All right. So I want to draw those two locations a little bit larger so I can put the receptors on there. Different on her phone than it is on yours. So coming out of the central nervous system, either the medulla for the vagus nerve, or the other cranial nerve, or sacrosplanchnic nerve, that is the preganglionic neuron. It is going to have an axon, and that axon is going to form a synaptic bouton, and it's going to be releasing the neurotransmitter, which is acetylcholine. I obviously simplified this. So this is our synaptic bouton of the parasympathetic preganglionic neuron. And it is forming a synapse with a postganglionic neuron. And this would be at the cell body or a dendritic spine. So this would be, say, the dendrite of a postsynaptic neuron. So where would this whole area be? Exactly. This would be in the autonomic ganglion. So ciliary ganglion, intramural ganglion, this would be the ganglion. You guys are catching on so fast after a semester of listening to me. So the receptor that binds this ganglion, this neuron, is an ionotropic receptor. It is an ion channel that will bind acetylcholine and will open, and when it opens, it allows sodium ions to enter into the postganglionic neuron. Sound familiar? Is this going to result in depolarization or hyperpolarization? Depolarization. All right? So here's an image. Notice when we have an ionotropic receptor, the receptor itself is the ion channel. It is identified as a nicotinic acetylcholine receptor because in studying these receptors, scientists found that they preferentially bound the molecule nicotine, and it acted like acetylcholine to open the channel. So they could use nicotine to differentiate between this acetylcholine receptor versus other acetylcholine receptors. All right? So it really is an acetylcholine receptor, but we can narrow it from other types by the fact that it binds acetylcholine, that it binds nicotine. So it's called a nicotinic acetylcholine receptor. Hence, here. It is located on the postganglionic parasympathetic neuron. It is also located on the postganglionic sympathetic neuron. Remember I said both of the postganglionic neurons will bind nicotine, acetylcholine, and this is the type of receptor on skeletal muscle cells. So after Thanksgiving, when we cover the physiology of acetylcholine causing muscle cells to contract, it's a sodium channel. All right, it's not a G protein pathway. It's an ion channel. So this is what I was talking about earlier. If you took a cholinergic drug like acetylcholinesterase and had a cholinergic crisis, we can explain these different results because of these three different neurons that it binds to. Vomiting and diarrhea. Parasympathetic functions to increase digestive activities. So, too much acetylcholine, smooth muscle in your small intestine is contracting too rapidly and sending food through the food before it can be digested and absorbed. Diarrhea. All right? Convulsions. That's because the nicotinic receptors are on skeletal muscle cells. And when they bind this extra acetylcholine, they contract. So we have spasms and convulsions because of the skeletal muscle component. Salivation. Every time you talk, saliva comes flowing out of your mouth and covering everybody with a sticky, sorry for the picture, came out. So, saliva, salivary glands, sympathetic or parasympathetic? Parasympathetic, glossopharyngeal nerve, facial nerve. So all of those are due to excess activation of postganglionic parasympathetic neurons, or skeletal muscle. But we also have high blood pressure. Acetylcholine slows the heart down, and yet with too much acetylcholine, we have high blood pressure and rapid heart rate. That's a parasympathetic effect. That's due to, that's a sympathetic effect. That's due to norepinephrine. Why are we getting a bunch of norepinephrine when the person has too much acetylcholine? Because it's also going to bind to postganglionic sympathetic fibers. Right? And they predominate at the heart. In addition, postganglionic sympathetic fibers will actually release acetylcholine themselves in the skin on sweat glands. So profuse sweating is the acetylcholine binding to sweat glands because of the a few postganglionic sympathetic neurons actually release acetylcholine, and those receptors are ionotropic. So just to explain, and Tuesday we'll go over some of these drug effects and modulations and treatments. All right, so now our postganglionic neuron has its own axon terminal, and it has a synaptic glucan, which is releasing acetylcholine. But instead of binding to a nerve, it's going to bind to smooth muscle, our cardiac muscle. All right? So this is our parasympathetic postganglionic neuron. The acetylcholine molecule is still the same, but our receptor is different. So this is cardiac or smooth muscle, or a gland. And this receptor is metabotropic. And what's the letter that you think of when you think of metabotropic? G. It's not a channel, but because of the G protein and the activation of inositol triphosphate, IP3, or cyclic AMP, or the inactivation, we can affect ion channels. If those ion channels are potassium, and we open potassium channels, what's going to happen to the cell? It's going to become hyperpolarized. That's what happens in the heart. So when we drip acetylcholine onto the heart, we open potassium channels. Positive ions flow out of the cell. It takes longer for the cells to depolarize. Heart contraction rate slows down. through the use of these potassium channels that open. But what happens to the small intestine? Does it slow down or speed up? Its contraction speeds up. So in that case, we have sodium or calcium channels that open, and the cell depolarizes. So both are G proteins. The effect is what happens, what that G protein activates or inactivates. All right? So our ionotropic receptors, this is always excitatory. Between the pre and the post ganglion, when acetylcholine is released, it's always going to result, if there's enough of them, in depolarization. Okay? This can be excitatory or inhibitory, depending on what it does to the potassium, sodium, or chloride channels. This is identified instead of nicotinic, it's identified as a muscarinic because it was isolated using chemicals from mushrooms. And that hence we use muscarinic versus nicotinic, okay? But ion channel, G protein pathway. So let's, that's what I want to know. So when we look at the activities of parasympathetic, remember our general classification, this is what we'll end up with today. Our general classification of parasympathetic is rest and digest. So normal activity, constriction of the pupils, accommodation of the lids. So looking up close, salivary gland and digestive stomach activity, small intestine activity. So when you eat, does your blood glucose levels go up or go down? They go up. So you release insulin to control the body's uptake of that glucose. So the release of insulin is parasympathetic controlled. All right? So the increase is going to cause the pancreas to make insulin. We'll see with the sympathetic system, it causes the pancreas to make glucagon, which is what happens in response to several hours after you eat. Control of defecation and urination. Constriction of the respiratory bronchioles. Fight or flight sympathetic is going to be dilation. Heart rate slows down. All of these are done. The sympathetic has the opposite effect. The last one, number 9, sexual arousal and sexual gland stimulation, the two work together. They don't both do the same thing. Parasympathetic in male and female is responsible for erection. Sympathetic is responsible for the release of, say, the prostate gland secretions or the seminal vesicle gland secretions, some of the vestibular glands in the female. And then parasympathetic is responsible for ejaculation. So they have their own roles, but they work together for the sexual arousal and response.
And more okay. Next semester.
Yes, you will. All right, so so tomorrow we're going to look at, and you have this table, I think, in your lecture notes.
Oh, yeah.
It's on the similar tables on page 81. Actually, more detail. Actually, name. Page 81. It looks like this. So prior to that, you're in sympathetic. Okay. So I have several different types of muscarinic. There are several different types of muscarinic receptors. That's not something you have to know for comprehensive or something. But there's basically 5 types: M1, M2, M3, M4, M5. Some are excitatory, some are inhibitory. So when you're doing your take-home exam, if it's talking about that, that's why. Down on page 79, talks about the different types and goes into more detail. and some more vesicles. But yeah, we'll go into that next semester. All right, so don't go far. Jen should be showing up here soon for the eval.